My name is Dr. Mark Socinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also a thoracic medical oncologist and a member of our thoracic oncology program at the Advent Health Cancer Institute. One of the questions of importance today is how long to continue maintenance immunotherapy or maintenance immunochemotherapy in patients who achieve complete responses. How do you handle these sorts of things? Gratifyingly, it's happening more often than it used to be. Particularly, we didn't see that many CRs when we used to do maintenance chemotherapy by itself, but certainly in the maintenance immunotherapy plus or minus chemotherapy, we are seeing more of this. And maybe it's not true CRs, but maybe more near CRs, that there may be some residual stuff left, but we often think it may be related to the tumor infrastructure, if you will, fibrosis, scar tissue, these sorts of things that are left as the cancer kind of dies away. Now, the initial clinical trials that explored immunotherapy or explored chemotherapy, the initial chemotherapy trials really didn't have an endpoint for when you stopped maintenance chemotherapy. It got, most of the time, patients would say uncle because they would have some cumulative toxicity that would be outweighing the potential benefit that we were seeing with continued cytotoxic chemotherapy. In the immunotherapy era, the original trials defined duration of therapy to be 2 years. And we recently had some data to suggest that in those patients who do receive a full 2 years of treatment, whether they're in a CR or not, actually do quite well if you stop at 2 years. So this is a discussion that I have with my patients. I started at about 21 months. And I say, we're coming up on 2 years. We have a decision to make at that point. You're doing very well. I just had this discussion with a patient last week who is in a pretty close to a CR. And, she's had 2 years of pembrolizumab, and we're going to observe her at this point and keep an eye on it. I think the issue is that she's been in a CR for about a year. So the question is, should I have addressed this and gave her a break from treatment a year ago, when she was in a CR at that point? And, we just don't have data in non-small cell lung cancer to guide us when we're trying to make these sorts of clinical decisions. I have not yet to date, in anyone who's had a CR or near CR, I have kept to the party line of continuing it for 2 years, particularly if there's no evidence of any sort of immune-related adverse events. Now, most commonly, the most common regimen we use in practice is the KEYNOTE-189 regimen. And of course, the maintenance strategy there was to employ both pembrolizumab as well as pemetrexed. Now, I have run into a number of issues with maintenance pemetrexed in terms of cumulative toxicity, fatigue, anemia, sometimes some skin changes, lower extremity edema, so on and so forth, where we've decided to stop the maintenance pemetrexed but continue the pembrolizumab by itself, which tends to be better tolerated than either the combination or, I would argue, maintenance pemetrexed in that setting. So I would like to have more data. I believe there is some data in melanoma suggesting that shorter durations of therapy in patients who achieve CR are reasonable. However, I don't know that we've explored that in non-small cell lung cancer. There is one trial done by one of the Checkmate trials that tried to address randomizing patients at 1 year if they were in a response, not necessarily a complete response, of stop at 1 year versus continue on beyond that. And The message from that trial, although I think it was a very difficult trial to interpret for a number of different reasons, the message from that trial was that maybe 1 year is not enough. And so that's kind of quelled the enthusiasm for considering stopping it sooner than 2 years, at least in lung cancer. So my advice would be to stick to that 2-year duration of therapy with the immunotherapy. If you're delivering it with cytotoxic chemotherapy, I'm very happy to discontinue the cytotoxic chemotherapy if there's issues with cumulative toxicity. It's most often, I mean, the only one we use in the maintenance setting from a cytotoxic point of view is pemetrexed. And sometimes now that we can give pembrolizumab on an every 6-week basis, I have no data to do this, no evidence to do this, but in those patients that are getting pembrolizumab every 6 weeks, I give the pemetrexed every 6 weeks. Again, I have no data to do that. However, patients tend to tolerate, it's essentially giving a little bit of a break with each cytotoxic cycle, and they tend to tolerate that better. And I still think there's a cytotoxic effect, which I do think is beneficial in combination with immunotherapy. And so I've adopted that sort of strategy in some selected patients in advanced non-small cell lung cancer.